Support provided by Walters Papillon Thomas Cullens, LLC, specializing in business litigation and personal injury cases for over 40 years.
Thank you, everybody, for inviting me to come and share some of my experiences with you. As I'm sure you can imagine, I'm a cardiac surgeon, and cardiac surgery is very complicated. It is meticulous, and it is stressful sometimes. When I was preparing for this talk today, I was trying to rack my brain to figure out what kinds of things about heart surgery that I could tell you that you would be interested in. And so I watched a few Grey's Anatomy episodes. Tried to figure out exactly what kinds of things really people wanted to hear about, but I kept coming back to the same thing, and that is really something that has become very special to me, and it's the relationship that doctors have with their patients. So one of the things that I thought about when I was preparing was to relate to you the story of my very first heart operation that I ever did on anybody as the lead surgeon. When I had finished my training, I thought I knew everything about heart surgery, and I had studied all the books, I'd passed all the board exams, I'd had a lot of really amazing influences in my short career up until that point. And I got a call around midnight, my first week on the job, from the emergency room doctor, and he says to me that he's got a little lady named Mary who is 80 years old. She has what's called an aortic dissection. And this is a life-threatening emergency. Most of the people who have this problem don't even make it to the hospital. It is where the blood, when your heart pumps the blood to the rest of your body, it gets in between the layers of the aorta, which is the main blood vessel that takes the blood to the rest of your body, and eventually will rupture the aorta and the patient will pass away. So he said to me that she's 80 years old, but she's a good 80. And she wants me to come and see if I can fix her aorta before something really, really bad happens to her. So I went to the emergency room, and I was on the way there, and I was thinking about all the myriad steps that we have to go through to accomplish the operation, if the perfusionist was going to be ready, if the anesthesiologist was going to have his game face, and what kinds of things I needed to do to get ready to hopefully save this lady's life. And I walk into her room, and she's there, obviously not doing very well. And I go through all the things that I've been taught to tell her about the surgery, and what kinds of things were going to happen, and how difficult it was going to be for her to recover, and so forth. And she looks straight at me, and she says, "Well, I think it's going to be okay because you have kind eyes." And so all of these things are racing through my head, and I'm thinking about the 100 steps down the line when I'm supposed to be doing this surgery on her, and she brings me back to reality and tells me that she trusts me to operate on her heart because I have kind eyes. And that process of the interaction between the doctor and the patient, and how someone that I don't even know can trust me to open up their chest. In her case, with the dissection, we have to saw through the breastbone. We put the patient on the heart-lung machine. We cool the patients down to about 18 degrees centigrade so that it slows down the metabolism to a crawl. We pack their head in ice. We give them a bunch of medication to try to stop the metabolism of all the nutrients in their body. And we open the heart and we turn off the heart-lung machine. So the patient is laying on the table with no heartbeat, with no blood circulating through their body at all. You have to do this because in order to be able to operate on that part of the body, you can't have blood in your face, and it's important to be able to see to meticulously place those stitches. So we finish the operation, and we have to rewarm the patient slowly because it injures the cells in the body if you rewarm too quickly. We finished the operation and got her to the recovery room, and she eventually did relatively well, had to spend a couple of weeks in the hospital, but went home and was able to live after the surgery. And it was a very touching thing for me because of all this preparation that I had been through. It didn't really prepare me for this little lady telling me that she was going to trust me with her life because I had kind eyes. So to understand how complicated heart surgery is and what kinds of things we have to think about, why we have to think about these things, I think it's important to be able to reflect on the history of surgery, and specifically cardiac surgery, and how we've come to where we are, to where heart surgery seems like somewhat of an afterthought that people will do well, and we have become very good at performing complex heart surgery, and most of the time people end up doing very well. Some of you will recognize this as a trephinated skull. So these skulls like this, with surgical wounds like this, have been found all over the world in disparate places, places that would never have been connected to each other in any way. Of Stone Age surgeons trying to cure people by thinking that they could put a hole in someone's skull and that the bad humors would come out and they would be okay. Whether this was for religious reasons or scientific reasons at the time, we will never know. But the most amazing thing about these skulls that are found all over the world is that they show signs that these patients actually lived, that the bone on the outside fringes of this hole actually showed signs of healing, which means that 5,000 years before Christ, people were trying to do surgery on people with the intent of having them live afterwards. It is an amazing thing, I think. And there have been a number of other events along the way that have really gotten us to where we are now with regard to surgery. This guy is a guy named Frère Jacques. Most of you have heard of Frère Jacques because you sing nursery rhymes to your kids in French sometimes. And this is one of the main subjects of those French nursery rhymes, Frère Jacques. This is actually not the same Frère Jacques, and people have been very interested in this fact that they're not actually related. This guy, he's got a sinister look on his face for a reason. Back after the Renaissance, in the Age of Enlightenment, surgery was a spectacle of entertainment. People would perform surgery in public squares as a matter of entertainment for villages all over Europe. And this gentleman was an expert at the retrieval of bladder stones. And so he used this little implement that he has in his hand to extract a bladder stone from someone without anesthesia. Obviously, anesthesia hadn't been invented yet, so he was known for doing 5,000 or so of these operations all over Europe in public, trying to cure people of their bladder stones. Sometimes it went well, oftentimes it did not, but the spectacle was the most important thing. This was the Grey's Anatomy of the 18th century. And so you can imagine that surgeons would get a bad name by going around doing all these performances all over the world. And this is an etching that shows the actual process that Frère Jacques used to try to, he had to solicit some of his friends to come and help him and hold people down so that he could do these operations. But nonetheless, he did them, and this was the beginning of surgery as performance art. But certainly, luckily, we have progressed remarkably since then. And at Harvard University in the 19th century, we have the invention of anesthesia with the Wharton ether inhaler. This allowed us to be able to perform surgery on people without having them feel pain. This was actually dental extraction, but nonetheless, this process was adopted and really kind of helped surgeons gain some respectability in being able to take care of these problems without the patients having pain. And more specifically, as it relates to cardiac surgery, this man, John Gibbon, was tinkering around in his garage and decided that he was going to try to make a device that would allow you to support the circulation of patients while you worked on the heart. And this is actually the first prototype for the heart-lung machine, also known as the cardiopulmonary bypass machine. It looks like something that you might be able to contrive in your own garage, I'm sure. And but nonetheless, this brought heart surgery into the forefront of surgery. The last frontier of surgery was able to be overcome by placing patients on the heart-lung machine for a time so that they could recover from whatever we were going to do to their heart. A landmark day in 1952. One of my mentors, a guy named David Savaston, in 1962, only 10 years after this contraption was invented, was the first person to perform a bypass operation with a saphenous vein from the leg, something that we do most every day now and is one of the most common procedures done in America today. Had quite an influence on me because of the history. It's very important to all of us. And this ushered in an era of maximally invasive heart surgery. We could perform all kinds of amazing operations on people's hearts, and this is actually a picture from the first heart transplant operation, which was performed in 1967. We were able to invade spaces in the body like we had never done before. And it gave us an opportunity to be able to help people who were sicker and sicker and sicker with all of these large involved operations that took 10 or 12 or 14 hours, and people would survive. And this was actually one of the most exciting times for cardiac surgery. After this, we started operating on more and more people with heart maladies, and we had to try to figure out how we could improve. We didn't have a problem finding people to operate on. There were lots of people to operate on because cardiovascular disease is actually the most common problem that we have in America that needs surgical intervention. And most people don't realize that heart disease kills more people every year than all types of cancer combined. So I like to refer to it as cancer of the arteries to my patients. So nonetheless, we were able to perform really complex operations on people, and the only way that we were going to be able to improve upon that is to do it more safely and to improve the quality of what we do. When we think about quality, of course, we think about survival. We also think about the prevention of morbidity or complications. So we try to figure out how we can do things less invasively to allow people to return to work faster, or to have less pain, or to have less trepidation about actually having their surgery. This picture, I have to give a photo credit to Edgardo Tenerero, who's the CEO of Baton Rouge General. And I think he's a member here as well. He is, we share a lot of passions, one of which is taking care of people with cardiovascular disease, but we also share a passion for photography. He's quite an accomplished photographer, and I encourage you to ask him to show you some of his work sometime. But in 2010, at Baton Rouge General, we actually performed the first minimally invasive mitral valve repair on a patient in this region. And you will see me there working through a very small hole in the right side of this lady's chest, and you can see on that TV monitor her mitral valve, the inside of her heart, that I am visualizing with a little scope that's there to the left of my left hand. And so we have a testimonial. She says her husband had transcatheter heart valve replacement, and he was oxygen dependent beforehand and had the operation, and within 2 weeks he was totally off oxygen and back at work. It is remarkable.
Hey, Doc, with the new technology that you showed us again there, how much time is reduced in the operation room?
Yeah, that's a really good question too. And so, as I alluded to in the beginning, heart surgery is very, very complicated and meticulous. We spend perhaps 3 or 4 times more time preparing for these operations than we do actually doing them. And I'll give you an example. For a conventional aortic valve replacement with surgery, we might prepare for that about 30 minutes and review the studies 2 or 3 times, perform the surgery, which takes 3 or 4 hours, and the patient spends 2 weeks recovering from that. For a transcatheter aortic valve replacement, we spend an exceedingly long amount of time preparing and making meticulous measurements because we're trying to work on the heart from the groin. So you can imagine how much more room for error there is if you're not really precise in the measurements and the conduction of the operation. So we spend a significant amount of time preparing to do those operations, even though those operations take about 20 to 30 minutes. It is amazing how much more preparation is involved.
Hey Doc, over here. Yeah.
Yes.
I've done some consulting work for Intuitive Surgical in Silicon Valley with the Da Vinci system, and I know that doctors, it's a robotic surgical system that doctors have to train on, and it's a new technology. And can you, from your perspective, what's it like to have this interface with these robotic systems and get trained to do that? That must be challenging.
Well, that's a good question. His question refers to robotic surgery and what's it like to have a relationship with the robot, so to speak. And it is really an intimate relationship and it takes a lot of time. We spend hours training on simulators and using these surgical robots to try to improve on our technique before we actually get to a patient. We start off with things that are relatively easy. For instance, when I was learning how to do robotic surgery, one of the things that I really liked doing more than anything else was just doing biopsies of the lung for patients who had lung cancer or some sort of a mass in their lung. Because of the fact that it is not as high acuity as performing heart surgery on someone, it allowed me to develop the dexterity with the robot to be able to do more complicated things. And the Intuitive people are phenomenal at supporting surgeons as they go through this learning curve, giving them an educational pathway and a technical pathway to be able to make steps where they get better and better at doing things that are harder and harder. And they deserve an insurmountable amount of credit for how they have laid out the training and education programs for the surgeons that end up doing robotic surgery like me.
Right.
Doc, this is a personal question. Beyond the obvious diet, exercise, nutrition, cholesterol numbers, what are the things that you do personally to protect your heart health, maybe at a deeper level that most people don't hear about in the news, or maybe they've heard a little bit about, but you think may have some promise in detecting early on and preventing heart disease?
Yeah, that's a good question. And, I know a lot of cardiologists. And one of the things that I know for sure is I want to do everything I can to stay off the cath lab table. And so everybody that I know, I try to encourage them to optimize those things that they can. There are some things that you will never be able to impact. Your parents, you can't pick your parents. So your genes are your genes, and you're stuck with those genes until we have gene therapy that can change those things. Also, you can't pick your age, and most of the time you can't pick your sex. So there are some things that you really cannot impact. But there are some things that you can impact. And the most important thing is that you go to the doctor at least once a year, every year, even if you feel fine. Because there are things that can, if they are impacted very early on, can potentially be life-saving. Taking the medicine that your doctor recommends for you is really important. Every day I tell the patients, every day that you misbehave and don't eat a low-fat, low-cholesterol diet, or don't take your cholesterol medicine, or don't take your hypertension medicine, or don't control your diabetes, every day that you don't do one of those things takes a day off the end of your life. So it's important for us to be vigilant about things that are going on with our health and diligent about what our doctors ask us to do. But you have to go to the doctor, and men are notoriously bad about that. But you have to go to the doctor in order that you can have these things looked after if they become a problem.
All right. Thank you, Dr. Keller.
Support provided by Walters, Papillon, Thomas Cullens, LLC, specializing in business litigation and personal injury cases for over 40 years.